May I now invite our fifth speaker, Mrs. Sulakshana Nandi, who is going again to speak about some empirical findings on RSBY coming from Chhattisgarh. Mrs. Sulakshana is the state convener of the Public Health Resource Network in Chhattisgarh, and she has extensive experience and expertise in training, research, and advocacy. Mrs. Sulakshana, please, the floor is yours.
Thank you. Can we go to the presentation? Yeah. Good afternoon, everybody. I'll just start because we don't have much time, and please let me know when we're at the fag end of the presentation. Yeah. So just a brief introduction of RSBY and the studies which I'm going to be presenting. Basically, these are 3 studies which we did in Chhattisgarh. And the studies were examining, one, the design issues and how they have sort of, they have implications for practice with the providers, and also whether the objectives of RSBY are being fulfilled with a very special focus on marginalized communities and remote and underserved areas. These are the 3 studies. I'll request you to just go through the slides. So we, one was on enrollment, which was a quantitative study, which groups who are part of the People's Health Movement, they went to the villages they were working in and basically tried to find out the status of enrollment in those villages. The second one was on design issues, where we went to the public health providers, and which PHRN did along with GNU. And I just want to take 2 minutes more on this study. When we presented our first RSBY study in 2008 at EPHP, I mean, I think that was one of the initial, I mean, the initial days of RSBY, and not too many studies had come out. In the last 2 years, we do see a lot of studies happening on RSBY, and but we felt that most of the studies were focusing on the beneficiaries, which they should. But we wanted to go to the providers and also gauge their experience and document their experience in implementing RSBY. The third study was part of a broader initiative with PTGs in Chhattisgarh. So first, findings for the first, I mean, the 2 studies on enrollment and usage with the PTGs and with the People's Health Movement. The study on enrollment showed there was very low enrollment, 30 to 40% of the population was enrolled. No enrollment in remote and inaccessible villages. This lack of information and awareness, the list of hospitals was not received by 67% of the villages, and only in 25% of the villages had anybody used RSBY, and there was still high out-of-pocket expenditure. The study with the PTGs, where we interviewed 1,200 PTG families, Bega, Kamar, and Pahari Korwas. Now, PTGs are Antodaya card holders. They get rice at 1 rupee per kilo. They are the most marginalized, most impoverished group of people. And only 32% of the families had been enrolled under RSBY, and positively 4% had at least utilized RSBY. Now, in the experience of providers, this is the study which we did on the design issues, where we went to the providers. I will take it one by one. The first is on technology. There were problems of poor connectivity. I just need to add to this that we went to private providers, public sector, and the not-for-profit sector. So in Chhattisgarh, a lot of the primary health centers have also been empaneled under RSBY. So especially in the primary health centers, there was an issue of poor internet connectivity. Training was inadequate or completely non-existent. There were some issues with swiping of the smart card, which led to certain defensive practices, which I will elaborate later on. Software needed to be changed with every TPA, so that hospitals had great issues with that. And in fact, Raipur, which is the state capital, three CHCs out of the 4 CHCs were not functioning under RSBY because their software just could not be updated. This was happening at the state capital. In terms of enrollment, annual enrollment, both from the side of the providers, seemed to have questionable utility. As my friend presenting the Gujarat study also said, here the providers also told us that practically only for maybe 8 or 9 months the card was usable in a year. All this renewal and all that took 3 to 4 months, and they were not able to provide the services under RSBY during those months. Now the TPA does the enrollment and also manages the claims. It brings up the issue of conflict of interest. And from the providers, especially providers who are working in tribal areas and in very inaccessible places, and who had a sort of interaction with people, with really poor people, and poor communities, they in fact told us that a lot of the people who come to their hospitals from the remote villages had not been enrolled under RSBY. Settlement of claim, there didn't seem to be any rationale for settlement of claim. It was completely ad hoc. And in fact, there was a change of the TPA, so the people were much more happy with the current TPA, and the previous one got blacklisted. So yeah, they had a very bad experience with that. There was no grievance redressal system in place in case your claims got rejected. There was nobody you could, talk to or complain to. And the biggest part is the TPA seemed to be really playing riot. I mean, there was no penalty on the TPAs for delaying the claims. They're supposed to clear the claim within 15 days. So the insurance company would give them the money, but they would sort of keep it and not really disburse it to the hospitals. And that was a real big problem. And there was no penalty on the TPAs in case they were delaying the claims. And this is supposed to be a universal scheme, which is supposed to be, the card is to be used anywhere in India, but there were major problems in other state or other district districts having a different TPA. There was a problem in settling the claims. Now, I want to go through these 3 slides in terms of, we found very different experiences with providers of the public health system, the private health system, and the not-for-profit hospitals. The private was clearly providing very narrow and selective range of services, while the not-for-profit was providing a large range of services, while the public was providing a very limited, again, a range of services. Hardly any surgical procedures in the public, only except in the medical college, only sort of, drainage of abscess or your incisions, tubectomies. This is what was happening in the public. In the private, there are very few medical conditions. Now, there are 2 types of conditions under 2 types of packages. One is your procedures or your surgeries. The other is a daily amount which can be claimed for certain medical conditions. For example, anybody comes with diarrhea and you're like admitting that person, so 750 is the rate which the hospital can take on a daily basis. Now, these conditions, these medical conditions, which I guess form most of the issues, most of the conditions in our population, they were not at all being treated by private hospitals. Whereas the public hospitals were the ones who were only treating the medical conditions, and because they didn't have the capacity, they were not doing the surgeries or any complicated procedures. Ironically, private, if the cases got too complicated, they would just refer it to the public sector. Great advantage for the private sector. I mean, most of the people we interviewed a range from corporate hospitals to your mom and pop or to your specialty, dental, orthopedic hospitals, eye hospitals. Great increase in caseload, and your mom and pop hospitals, they have smaller nursing homes were the biggest gainers, because they usually had a gynecologist and a pediatrician, that sort of this thing. And whereas the corporate hospitals, where actually you expect your catastrophic expenses to happen, hardly had had very limited RSBY occupancy. And there has been an increase in incomes of the private sector. They clearly came out with it. Not-for-profit also experienced an increase in caseloads. But in case, for example, smaller mission hospitals, if they had to call a gynecologist or somebody from outside, so they reported some losses. Public sector hospital clearly reported decline in patients and decline in services. In fact, in one district, the hospital was providing delivery services. It was a district hospital. It was providing a number of surgeries, which it stopped providing after RSBY, because there were many more private hospitals in that district, which later got pulled out for this whole hysterectomy, to whom the patients were then going. I mean, some of the issues we brought up on in terms of, the public providers doing private practice. When we asked a number of the public hospital doctors, अच्छा कोई आपके यहाँ का कोई अच्छा hospital बताओ जहाँ RSBY चल रहा है, जहाँ हम interview कर सकते हैं. So they would give names of the hospitals they owned or they partly owned. So they were also managing a lot of hospitals which are under RSBY, the government doctors.
Mrs. Sulakshana,
yes.
Slowly backing up, please.
Okay, yeah. But in public sector, we saw an increase in patients in the tribal blocks because there was no private sector, so it was very evident. Very critical thing, previous maintenance funds were withdrawn in the public sector. And in Chhattisgarh, they have a unique scheme in which they, 25% is given as incentives to the government people all over in RSBY. And the rest is supposed in public sector, and the rest is supposed to be given to the hospital. Now, Chhattisgarh has an innovation in which it takes away 40% of the funds as a central fund, which is managed at the state level, which they're calling it a Chief Minister's fund. Yeah, Chief Minister's Hospital Fund. Uska utility, one doesn't know, it has not been spent. It is under the control of the SNA. So, in terms of packages, most packages price lower than hospital rates in the private hospital. Fixed number of beds, hysterectomy preferred by the gynaes rather than cesarean section because the package amount is less in cesarean. Ophthalmology, more cataracts. Not-for-profit, most of them had lower packages than the... So this actually also talks about what is your rational, what is the cost of care, and if the private is saying this is much lower than what we take, and a not-profit is saying this is much higher than what we take. So in public, see, they clearly said the packages or even the medical condition, the 750 per day, is not possible for very long-drawn illnesses like snake bite or poisoning or things like that. And they would commonly just any person who comes, because they have a pressure to show a lot of utilization in RSBY. So they were basically admitting a lot of people for weakness and hypocalcemia for 3 to 5 days, in which they would just do some your HB test, some blood sugar tests, and just give them some tonics and stuff like that, and keep them inside the hospital for 5 days. So we did an analysis with the standard treatment guidelines and the Red Cross drug list. So any condition like malaria, diarrhea, which was going to cost around 100 rupees for a patient, and which would also not be an inpatient thing, was actually now, that patient was actually, 3,750, like 5 days of hospitalization was shown. And yeah, okay. Yeah, so is RSBY able to reduce catastrophic expenditure? Is it expanding the choice of services? Has it guaranteed services to the people? And is it able to rope in private with a regulatory framework? We feel that our studies show that there are major questions on this. So clearly, in Chhattisgarh, it has not been able to achieve complete coverage in terms of population or in terms of the types of services which are being provided. And the most critical thing of this is that the vulnerable communities are being left out. And there is no guarantee of services. A person with diarrhea going to a private health center, private facility, there's no guarantee that the private facility is going to treat that person with diarrhea under RSBY. Huge advantage, like I said, is cherry picking. There is no real choice to the consumer because it's very clear. Malaria, you go to the CHC, and hysterectomy, you go to the private nursing home. Public sector is unable to compete and is weakening. Costs of care are being artificially inflated. Poor is not protected from catastrophic expenditure because those very high-end things are not happening. Procedures rather than illnesses. So if a person, a woman is most likely to undergo an hysterectomy rather than treatment for an RTI, under RSBY. So recommendations, I think you could just read these. Yeah, I just want to highlight on the focus on inclusion errors. People who are getting left out are the people who need it the most. So that is something we really need to focus on. And I think we need to keep remembering this. Thanks.
Thank you very much, Mrs. Sulakshana, for your drive with this presentation, which you went a bit over time, but you had lots of interesting and challenging things to share.